So why don't we go ahead and get started? So today's topic is peripheral arterial disease, and originally it was slated for two speakers. Shah was going to talk a little bit about vascular ultrasound and the disease process in general, and I was going to talk about imaging and specifically MRI and CT. But since he is tied up in his clinic in Pearland, I'll give you the overview of both. So obviously, what are we talking about when we talk about PAD, peripheral arterial disease? So it's really disease in the, we're going to focus primarily on the lower extremities here. And patients present with a variety of different symptoms. And I think, the important thing to keep in mind is that many patients with PAD actually can be completely asymptomatic. That means they have no obvious signs or symptoms of impairment from having peripheral arterial obstructions. Then patients can come in with the classic claudication symptoms. And a couple of important things to keep in mind with claudication is that it tends to be reproducible symptoms that occur with a specified duration of exercise or intensity of exercise, and that they get better with stopping the exercise with rest. So that's an important thing to keep in mind, because that's different than people who have atypical leg pain, which is either pain that doesn't occur with exertion, pain that is not consistently reproducible at a certain duration or intensity of exercise, or pain that doesn't improve with rest. And this just kind of goes through and points out some of the kind of ways or features between true claudication and what we call pseudo-claudication. And again, on the left-hand side, if you look at true claudication, it tends to give you a cramping, a tightening, an aching, or a fatigue type symptoms. It can be, we typically think of claudication as affecting the calves, but it can also affect the buttocks, the hips, or the thighs. And to some extent, that location can also give you an idea of what the anatomic location of the lesions are going to be, with buttock and hip pain, thigh pain more commonly being associated with aortoiliac disease, whereas calf and foot would more commonly be associated with femoral level disease or further downstream. Again, claudication tends to occur with exercise, where pseudo-claudication can be variable. Claudication occurs with a set distance. Pseudo-claudication can be variable. True claudication should not occur with standing, and it should obviously be relieved with rest, typically within a few minutes. Also important to keep in mind is the differences between acute limb ischemia as well as chronic limb ischemia. So limb ischemia in and of itself means that there's, or critical limb ischemia means that there's ischemic rest pain, non-healing ulcer, or gangrene. And then when you have acute limb ischemia, you have the kind of the hallmark of the classic 5 Ps. And these are pain, pulselessness, pallor, paresthesias, and paralysis. And so most of these patients that present with acute limb ischemia are going to generally go to the vascular surgery service. So we're not necessarily going to see those patients ourselves in the cardiology clinic, but the patients that we are going to see oftentimes are the patients with the classic claudication symptoms, or the patients with chronic limb ischemia, which can oftentimes be very critical. So I think the first step that you have really is to identify, first off, whether the symptoms are typical or atypical, and if they're typical, to determine if the patient's having claudication versus they're having critical limb ischemia. And the difference, obviously, between claudication, which is symptoms with exercise that are relieved with rest, and chronic critical limb ischemia, which means that they're symptoms that persist during rest. And so that can be either rest pain, that can be non-healing ulcers, things like that. Irrespective of the presentation, the way that we're going to really start off with is an initial assessment is by an ankle brachial index. So does anybody know how we do an ankle brachial index, or an ABI, as it's commonly called? Okay, what was that? So ankle brachial index. So obviously the simple thing is it's ankle to brachial index, right? So how do we determine ankle?
So you use Doppler and you take a dorsal pedis and posterior tibial, you get the blood pressure by Doppler of dorsal pedis or posterior tibial.
Okay.
And then you use, for that leg, you use the higher of either one of those and compare it to the higher of either brachial.
Okay, so the key thing, right, is that for the denominator, which is your brachial pressure, you want to take the higher of the two brachial pressures that you achieve. So yeah, a couple of things. Obviously, it's performed importantly in the supine position. You don't want to do this immediately after you've been exercising the patient. You know, the rest ABI is going to be performed when the patient's in the supine position, you know, with some period of time between having done some maneuvers. And then you're going to want to measure all of your pressures with an arterial Doppler, and it's important to use an appropriately sized blood pressure cuff, and you want to have the edge of the cuff about 1 to 2 inches above the location of the pulse. And also important that the width of the cuff should be approximately 40% of the circumference of the particular limb. So again, you may need to use different size cuffs between for measuring the brachial versus measuring the ankle leg pressures. And then you're going to measure systolic pressures in both the right and the left brachial arteries, followed by measuring it in both the right and the left ankle arteries. And this actually just goes through and talks about the steps involved. It's important for the Doppler, make sure you apply gel to the surface so you get a good Doppler signal. And then you want to turn the Doppler probe so that it's about 45 to 60 degree angle with the surface of the skin. And then make sure you move the probe around until you find the location where you get the clearest arterial signal. And this is actually showing you how it would be done. So here we are, we've got the blood pressure cuff here on the arm, and then we're going to measure the brachial pressure, and then we would do this both in the left and the right. And then we've also got the blood pressure cuff here now on the calves, and we're going to want to measure this both at the at the dorsalis pedis and at the posterior tibial locations. And then, typically you want to inflate the blood pressure cuff to approximately 20 millimeters of mercury above the point where systolic sounds are no longer heard. Gradually deflate the cuff, and as the pressure comes down, look to see when you begin to hear arterial waveform sounds. And then obviously it's going to be the ratio, as we talked about, between the ankle systolic pressure divided by the higher of the brachial artery systolic pressure. And then what's considered a normal ABI? Yeah, so it should be normally above 0.9. If you start to get values over 1.3, you begin to worry if there's non-compressibility or calcification of the vessels, and that actually may be a sign of abnormality as well. What's the population that's at greatest risk, and which are the patients that you need to be thinking about this in? So obviously people, even under the age of 50, if they have diabetes and an additional risk factor. In general, people between the ages of 50 and 70, if they have a history of smoking or of diabetes. And then obviously all patients over the age of 70, we need to think about this. And certainly people who have coronary disease, carotid disease, renal arterial disease, vascular disease anywhere, you need to be concerned also about having vascular disease in the legs. And then certainly patients who have classic symptoms or patients who have an abnormal pulse on examination. So obviously it's important that you always make sure that we check a pulse on all patients really. And then in cases where the vessels are non-compressible, that's where you want to use a thing called a TBI or toe brachial index, where you're simply measuring the toe pressure to the greatest of the brachial pressure and using that to compute your toe brachial index. This is showing you now what's considered normal and abnormal. And again, so really normal should be between 1 and 1.3. Between 0.9 and 1 is kind of your gray zone. You consider that borderline. And then between 0.4 and 0.9 will be considered mild to moderate disease. And then less than 0.4 for an ABI would be indicative of severe disease. And then obviously greater than 1.3 would also not be considered normal. And it could be indicative of non-compressible vessels. Let's get past this here in the interest of time. And this is just showing you how a toe brachial index would be measured. So the important thing I think to keep in mind is that an ABI measurement, we can do, all of us could be able to do that in the clinic. I don't think it requires a lot of fancy equipment. And it's something that's fairly simple and straightforward to do. And then what's considered for the toe brachial index, we use these special cuffs that go on the toe. Some labs consider a toe brachial index of less than 0.7 to be abnormal, indicative of PAD, and some labs will use a cutoff of 0.6. So it's between 0.6 and 0.7. If the toe brachial index is less than that, that's indicative that there's underlying peripheral arterial disease. There's other things that you can do as well, and it's important to keep in mind that the rest ABI is only giving you a measure of what's happening at rest. And so in some people, I think the rest ABI can certainly be useful for ruling out, a critical limb ischemia, but it may not be useful completely for ruling out claudication for exercise-induced symptoms. And in those cases, you can proceed on to do an exercise ABI, and the way that's done is essentially you do a resting ABI, then you have the patient exercise on a treadmill for 5 minutes duration, and then you come back and remeasure their pressures again, and you look to see if there's a drop in their ABIs between rest and between exercise. And that's indicative of an abnormality as well. Yes?
Quick question. In a patient that already has cardiovascular disease, coronary disease, big time risk factor, you already are committed to good statin, uses, aspirin, pneumonia,
Right.
no symptoms in the legs. Really, what's the value of documenting PAD?
So
You're not going to do anything for the PAD.
Right.
You're going to treat the risk factors which you already are treating.
Right.
What is it really worth, the extra time,
To-
the extra expense?
think about that.
Yeah. So that's a good question, which is obviously if they have symptoms, you have a reason. But even in the absence of symptoms, people with known coronary disease, if they have peripheral arterial disease, their prognosis is worse. So you're not going to alter your management, but it provides you with risk stratification, right? And so there's a lot of things that we do purely for risk stratification purposes. And so I think it helps you to identify potentially a higher risk individual. And sometimes also it may be useful in getting, if you're trying to convince a patient to stop smoking or compliance with some of the secondary prevention therapies, if you can demonstrate to them that they have disease in the coronary system as well as in the legs, oftentimes that may be helpful as well. But you're right. I think the key point, though, is that just because you have a lesion in your leg, the treatment for that is not to go in and intervene. Really, the indications for intervening for PAD in the absence of critical limb ischemia where you have rest pain or you have non-healing ulcers is really lifestyle limiting claudication. So simply having claudication and having an obstruction isn't an indication to go on to do something about it other than secondary preventive therapies. So you can also do segmental pressures where they actually will measure the pressures at multiple different locations. And the advantage of being able to do this is it can give you some guidance as to localization. So obviously this is not something you would do in an asymptomatic person where you're just trying to identify the presence of disease, but rather in somebody who's symptomatic, this is kind of your first step to try to be able to localize what's the location of the abnormality. But as we'll talk about later in this lecture, now we have more sophisticated ways to localize the lesions to help for planning of potential interventional procedures. So again, exercise ABI, the role for this, confirm the diagnosis, assess the functional severity of the claudication, and keep in mind that you may have normal resting ABIs in people who still have underlying PAD, and the exercise ABIs may be able to unmask that. So if you have somebody who has symptoms of claudication and your resting ABIs are normal, that hasn't excluded that this person has true PAD and true claudication. Exercise is important in that setting, and that's where then it can help to distinguish between true claudication versus pseudo-claudication, which is not due to peripheral arterial disease. What's a treadmill protocol? That's shown here. No incline. It's 4 kilometers per hour for a duration of 5 minutes. And, so it's not a graded exercise duration, rather it's a fixed duration. And then at that point, then you check the pressures. Now, this is kind of a busy slide, but this actually is kind of going and showing you kind of a proposed algorithm for what you would do. And obviously, if you have normal ABIs, then at rest in a person who has symptoms, then you could proceed on to doing it with exercise. And then if they develop an abnormality with exercise, that's indicative of PAD. If, on the other hand, their ABIs are reduced at rest, then obviously you've confirmed a diagnosis of PAD. And then if the ABIs are supranormal, greater than 1.3, that's when there may be value to going on to doing either duplex ultrasonography, pulse volume recording, or toe brachial index. And then obviously if that's normal, then you probably say the person does not have PAD. And if that's abnormal, then that's indicative of the person having peripheral arterial disease. Now let's go through and just define the vascular territories that we're dealing with. And it's important when we do imaging is we really want to make sure we look at this entire vascular territories. And so obviously it starts really up in the abdomen, where you want to look at the suprarenal aorta, the juxtarenal aorta where the renal arteries come off, and then the infrarenal aorta, which is an area more than 1 centimeter below the lowest renal artery. Then you've got the aortic bifurcation, which then gives rise to the common iliacs, the external and internal iliacs, and then subsequently the common femoral artery below the inguinal ligament. And then the common femoral artery then is broken down into the superior femoral artery and the deep femoral or profunda femoris. And then the superior femoral then becomes the popliteal at the level of the knee. And then you've got the infrapopliteal vessels, where there's a trifurcation, where you have the anterior tibial, the perineal in the middle, and then the posterior tibial. So the anterior tibial goes on to supply the dorsalis pedis, and the posterior tibial artery then becomes a posterior tibial at the medial malleolus of the ankle. So one of the tests that you can use is color duplex ultrasound, and you're trying to basically identify flow accelerations in areas that would correspond to obstruction. And some of the advantages of this, obviously, is that it can help you in localizing the area of the abnormality, as well as getting some assessment of the severity of the stenosis. Ultrasound can help you also in post-surgical cases where you're trying to look for patency of the bypass graft. And there's also techniques by which they can actually measure the amount of flow within the bypass graft itself. And the advantages here is that this is not completely non-invasive, and there's no need for contrast agents, so it can be done safely in patients with renal failure. And this is what the ACC/HA guidelines talk about as a role for duplex ultrasound. So it's a class 1 indication to diagnose the anatomic location and the degree of severity of PAD. It's also a class 1 indication to perform for routine surveillance after a fem-pop or a femtibial pedal bypass graft with a venous conduit. And then it's important that the surveillance duration here should really be at 3, 6, and 12 months. And then if you go past the first year, then you can do it yearly after that point. Next, let's move on to CTA. Obviously, this also is a fairly robust technique for being able to identify lower extremity arterial disease. And some of the advantages of CTA are it gives you a very high quality arterial picture, but it does require ionated contrast, and it does require radiation exposure. And the current indications for CTA, it's a class 2B indication. CTA of the extremities may be considered for diagnosis, as well as anatomic localization and to determine the severity of the stenosis in the lower extremities. And it's also indicated as a substitute when MRA is contraindicated for some reason. And then lastly, MRA obviously is the one I'm going to focus on the most. And I think the advantage of MRA now is that it can really virtually replace the need for doing invasive contrast arteriography for PAD diagnosis. Gives you outstanding pictures, no ionizing radiation, and then the contrast agent that we utilize are not iodine-based contrast agents, so there's not a concern in people who have renal failure. In people who have contrast allergies. And it's important to keep in mind, though, that if you have patients who have severe claustrophobia or pacemakers or defibrillators, or if they're too large to fit into the scanner, these are patients that may not be good candidates for MRI. And then obviously gadolinium can't be used in people with a GFR less than 30, or I shouldn't say can't be used, but we're very cautious about its use. But for arterial applications, we have also iron-based agent called ferromoxetol, which is very safe to use in renal failure patients. So I don't think that renal failure is no longer a contraindication for MRI scanning. Now, and this is what the guidelines tell you about the role of MRA. Useful for, again, both diagnosis, anatomic location, and assessing the degree of stenosis. Typically, it should be done with contrast agents because you're going to get the best results. And then when selecting patients as candidates for intervention, it's oftentimes important to do an MRA or CTA to get a roadmap of the arterial system before taking the patient to the lab for an intervention. Now let me talk a little bit about some of the specific details behind how MRA imaging is done. And so we start out with the important principles for vascular imaging is, one, you want to create a contrast between blood vessels and between background tissue. And there's a few different ways that we can do this. One of the ways is by exploiting the intrinsic properties of flowing blood to use that as a differentiating factor. But the one that we're going to use most commonly is by giving intravenous paramagnetic agents, contrast agents, which allow the blood vessel, which has blood flowing within it, to have differing T1 properties than vessels or than tissues outside of the vessel. And then, in addition to that, we have now some newer non-contrast-based techniques that we can utilize as well in patients that we're not able to give any contrast agents to. So this is kind of a busy slide talking about the different MRI pull sequences that we'll utilize. I wouldn't expect everyone here in the room to be familiar with all the details. I think obviously for the MRI fellows, you need to have this memorized, but for everybody else, don't worry about it. A couple of important things to keep in mind. There is a technique called time of flight, and this was actually been around since the early 90s. And this is a technique by which you're applying repeated radio frequency pulses that causes then a saturation of all the background tissue, as you can see here. But notice that since blood is moving, there's always fresh blood that's coming in that has not been saturated, and therefore blood that's moving in or flowing will actually appear bright, whereas all of your background tissue will appear dark. And I'll show you what that looks like. Here's an example of what that technique looks like. And so we make the blood appear bright based on the principle that it's flowing. Obviously, some of the limitations with this is what happens if you have slow flow, or if you have flow that's within the imaging plane. Those are all areas where you can get saturation, which can appear like a stenosis. And so those are some of the limitations with this time of flight technique. And that's why, although this was the technique that we used in the 90s, this is not the technique that we're going to use routinely today. Rather, today what we're going to utilize is what we call contrast enhanced MRA, and this is done with the administration of a contrast agent, either the gadolinium or ferromoxetol. Then we obtain a high resolution 3D data set, typically in about 10 to 20 seconds. You'll see the acquisition times are getting faster and faster. And this allows a very large field of view, high spatial resolution, and a very high signal to noise. And so it gives you an image that looks like this. Where notice the background tissue has been very nicely saturated and suppressed. So I don't see much in the way of background tissue, but the arterial structures show a significant amount of enhancement. So I can see the arterial structures very well. And one of the advantages of MRI is that the technique itself can fundamentally suppress the background tissue, so there's not the need for cropping out and cutting things out. Now, there's a couple of things when you're doing the MRI acquisition that are important to keep in mind. And I don't want to get into too much of the details of this for this talk, but I think it's important to keep in mind that when we obtain MRI images, each image is actually composed of different parts. There's what we call the center of K-space, which gives you information about image intensity, and the peripheral lines of K-space, which give you information about image detail. So, as I said, we take the image over 10 or 20 seconds, but each line of data that you acquire somehow contributes to the image in one way or the other. So the center lines, if I reconstructed an image with just the center lines of K-space, I still get a complete image, but notice it gives me information about image intensity, but not much about image detail. So I don't have very sharp borders here. The peripheral lines of K-space, on the other hand, give information more about the details of the image, and therefore, if I just sampled the peripheral lines of K-space without sampling the center lines, I would get very sharp demarcations or borders, but I would have no difference in image intensity between arterial structures and background tissue. And then obviously when you combine all of this together, that's when then you get a nice high-res image. The reason why it's important to know this idea is that when you're doing your acquisition, although the total acquisition may take 10 or 20 seconds to acquire, you want to do it such that the center lines of K-space are acquiring when the blood vessel of interest has got the maximum amount of contrast. So as long as you do that, then you won't get venous contamination. And I'll show you an example of that. So in this acquisition here, the center lines of K-space here correspond to A, okay? And you notice in these three example scenarios, if I obtain the center lines of K-space very early on after I begin the arterial contrast injection, contrast opacification in the vessel is not as great. In this case, it's crowded. If I time it such that my center lines of K-space are acquired at the peak concentration of gadolinium within the artery, then I get very high signal in the artery. But notice, at this time point right here, the veins have very low signal, so I don't get a lot of venous contamination. And so even though I'm taking my image over 20 seconds, the center lines of K-space are really only acquired in that middle 5 seconds. And therefore, as long as during that time the veins are not lit up, I don't get venous contamination. Now, on the other hand, if I acquire my center lines of K-space later on, when there's increased signal in the veins, now I have both the arterial and the veins lighting up as well. So this is a strategy by which, even though the acquisition takes quite a bit of time, you can time it in such a way that you don't get a lot of venous contamination. And this is probably the most crucial step when you're doing the acquisition, is making sure that you have the timing done properly. Because if it's too late, it gets very hard then to interpret the vessel, because you've got a vein that's right next to it that can obscure your visualization. If you do it too early, then the problem becomes that you don't have as much opacification within the artery. So that's where it gets to the next concept, which is how do we trigger our acquisition? And there's a couple of different ways that we can do this. One is by a technique that you call a timing bolus, where you actually inject a small amount of contrast. I can actually measure how long does it take for contrast to get from when I begin the injection to the vessel that I'm interested in imaging. And I can do a back calculation and say, okay, I'm going to do a delay of this amount of time. Whenever you do that, there's a formula involved, and there's always a room for error, because this is the formula, would be the delay equals the transit time plus the infusion time divided by 2 minus the time to the center of K-space. So already you can see, you try to do that to the scanner and you can screw things up. It's easier, more preferable to do it this way. We call fluoroscopic triggering. And this is the way that it's done most of the time in CT as well, which is that you basically either can have an ROI drawn and it identifies when contrast gets to a certain vessel of interest, or you can do this manually, which is I can visually see as I inject the contrast, I'm getting repeated images every half a second or so, and I can see the contrast which initially goes into the right heart, then it goes into the left atrium, and eventually it's coming out to the aorta. And if I'm interested in imaging the aorta, I would trigger at this point. If I were interested in imaging the pulmonary artery, I would trigger it once contrast is entered into the right side of the heart. So depending upon what vessel you're interested in imaging will determine how you do your timing. And then once I've got the contrast that's opacifying the vessel of interest, then I trigger this high resolution acquisition, which is shown here. And this is a full 3D volume, which again takes about 10 to 20 seconds to acquire, but it can give you, pixel sizes on the order of about 1 millimeter or so. And then lastly, there's a technique that's called time-resolved angiography. And what this is here is that I'm actually obtaining a series of low-resolution acquisitions every few seconds. And then I can simply go through and pick the time interval that I'm most interested in. And this is a way where you don't have to be concerned about timing, in the sense that I've got one phase, which is pulmonary arterial phase. I've got another phase, which is now the pulmonary venous phase. And I've got another phase, which is the aortic phase. Simply depending upon which phase I'm interested in looking at, I could then go and take that 3D data set from that phase and then interrogate that on my 3D workstation. The downside with this, obviously, is it gives you slightly lower spatial resolution, and the signal to noise is not as good, but it allows you to get multiple data sets, so you can pick the ideal data set that you want, and also gives you some information about contrast movement or contrast transit. Now, anytime you have a 3D data set, you have to decide how you want to visualize it. The simple way to visualize it is by doing what we call maximum, or what do you call it, MPR, multiplanar reformations. That's what these are here. These are just a series of 2D slices, essentially, one after another. And because it's a 3D data set, on the workstation, I could reconstruct these into axial slices if I want, into coronal slices, or whatever orientation I want to. In addition to that, though, you can also look at the data sets in what we call a maximum intensity projection. And this is what you do in the cath lab, where you look at a projection image. And so with this, what you're going to essentially be doing is looking at it from multiple different angles. And it's important because when you generate a projection image, the same 3D object, if you think of this Rubik's Cube here, and I've got some high intensity pixels here and here, if I project in the left to right direction, I actually project 4 high intensity pixels. If I project from this direction backward, on the other hand, then these 2 pixels are overlapping each other on a projection image, and so I would only see an image that looks like this. And so when you're trying to interrogate a vessel, if you're looking at a MIP, it's important to look at it from multiple different orientations. And a great example of this is for those of you that do cath. When you do a diagnostic angiogram, do you simply get one single AP projection? No. You typically are going to do multiple different orientations, right? And because, again, because remember, these are three-dimensional vessels, and you want to look at it from multiple different angles so you can identify the greatest stenotic severity. And then this, again, is what a maximum intensity projection looks like. But because it's a 3D data set, whereas in the cath lab, you have to go manually move your, II and re-sample each time. When you obtain a full 3D data set, we can do this all offline on a workstation. And this I'm showing you is now just a series of 3D reconstructions that are all done 10 degrees apart from each other. So I can actually have a full 336 images that give me the ability to look at it from all different angles. Now, when we're doing a single phase, it's pretty straightforward. I just want to get the abdomen. What if I want to get the whole lower extremity system? Well, I can't do that in one single acquisition. So I have to do what's called a bolus chase technique. So you inject gadolinium, and you actually gradually keep moving the table down. And so for most patients, this requires 3 to 4 stations to do this. So you get one station, a second station, and a third station. Depending upon the size of the patient, you may actually have to have 4 stations to cover from the toes all the way up to the diaphragm is typically at least what you want to try to get coverage to. And so if we're doing a multi-station technique, then we want to make sure that our contrast infusion is going for the full duration of our acquisition. And so typically we'll do this as a kind of a dual phase contrast injection where we give an initial dose of about 15 mLs of contrast of gadolinium or ferromoxetol that's given at a rate of 1.5 per second. And then you follow that up with a much slower infusion rate to try to maintain opacification of the smaller vessels as you get down to your thighs and your calves. Now, a couple other things that we'll typically utilize also, and these are ways to try to slow down that transit of contrast, because what you don't want to get is a lot of venous contamination. And so you can actually apply these things called MRI safe thigh cuffs. And what the purpose of these is to essentially raise the venous pressure in your legs. That slows down the venous return, and as a result, it slows the transit from the arterial to the venous phase. So basically just buys you a little bit of extra time where the arterial phase is lit up, but the venous phase is not lit up, reducing the incidence of venous contamination that can occur. And this is an example showing you here. On the left-hand side is an acquisition that's done without cuffs, and you can see there's a lot of veins that are lit up next to the arteries. And keep in mind, especially in the cath, it's very hard because the veins run right next to the arteries, so it can be very hard to distinguish between the two. Versus if you apply a MRI cuff, then all of a sudden you reduce the amount of venous contamination. You just have the arteries lighting up. So I think this is one important trick that we'll frequently utilize. And then this is just showing the diagnostic accuracy of the different MRI techniques, or at the different locations, I should say. For aortic disease, where you have a sensitivity and specificity in the high 90% range. For the femoral popliteal, also it's in the high 90% range. And then when you get down to the infrapopliteal tract, where vessels are much smaller, so resolution becomes an issue, and also venous contamination can become an issue because that's where the most contamination occurs. The diagnostic accuracy drops a little bit, but it's still in the low 90% range. And then also important, whenever you do a lower extremity study, is to not just do an arteriogram, but it's important to also do some post-contrast imaging that's done using this technique that we call VIBE, which basically is a technique which doesn't suppress the background tissue. And the reason is because I want to be able to not only look at the arterial structures, but also want to be able to look at the background tissue as well. Because remember, an MRA is just a luminogram, and it can be very misleading at times. The other advantage, obviously, of this technique is it's very good for looking at the veins. This is done about 10 minutes after the contrast injection. So therefore, contrast has gotten its way to everywhere where there's blood flow. So even areas where there's slow flow, contrast will get its way there. And so this is very useful, as you can see here, for looking at the veins and looking for stenosis or looking for thrombosis within the veins themselves. Okay, let's get past this. These are the technical parameters. And maybe just a few interesting cases. So obviously, this is a fairly straightforward case here of a patient who has really aortoiliac disease. And this is a person who comes in with classic hip and thigh claudication symptoms. And you can see, in fact, that there's extensive collaterals that are formed as well. And obviously, the workup for this patient typically would start with a rest and exercise ABIs. You confirm that there's an abnormality. Then you want to try to localize where the abnormality is and look at the extent of stenosis, because this will help now with surgical planning. Here's an example. I think the answer is already shown there on the bottom, but I have a vessel on the right side. I have my SFA here. There's no vessel on the left side, and that's because this person had an amputation. So always, it's important to make sure you look at everything. Let's skip past this one here in the interest of time. Here's an example also of a popliteal artery aneurysm. And you can see here there's a huge, huge area of contrast. And in this case, actually, it's not just a true aneurysm, it's a pseudoaneurysm where contrast is actually seeping out of the vessel itself. And this is where doing those morphologic imaging post-contrast can help you to identify if an area is thrombosed or just slow flow. And so in these cases, we're always going to want to look at the contrast MRA, but also look at the post-contrast acquisition, which is, again, called a VIBE sequence. Here's an example of a post-procedural complication here. And you've got actually a pseudoaneurysm that you can see here at the site of a diagnostic catheterization. What do we have going on here? I guess the answer is there. So if you can read, if you can read the images, you can figure it out, or if you can read English, you can figure it out. What's going on? What's the abnormality here? So here's my abdominal aorta, my iliacs, right? And then I go down to the femorals, right? And notice on the right side, the femoral vein's not lit up yet. On the left side, though, I've got a very opacified femoral vein extending up into the IVC. Now, the question is, there's other things that can also cause early venous contamination, right? There's things such as if you have, infection in that leg, that leads to a high transit, and that can cause early venous contamination as well. But one of the things, obviously, you need to be concerned about is, could there be an AV fistula? And if you see this where you have, especially if one side lights up the veins but the other side doesn't, that's a clue that there could be an abnormality here. And so then you want to go through and search through all of your axial images to see if you can demonstrate a communication between the artery and the vein. Now, let me wrap up here. This is again, the algorithm that you're going to want to utilize when you're evaluating patients with claudication. And again, starts out with a rest ABI. And if that's normal, but the patient's coming in with leg pain symptoms, you want to proceed on to an exercise ABI. And if that is abnormal, then the initial step is really medical management. But if they have, obviously, rest pain, signs of critical limb ischemia, such as non-healing ulcers, or if they have persistent disabling symptoms, so lifestyle-limiting claudication, then you would proceed on to some kind of anatomic imaging, whether it be MRI or CT, to define the anatomy and aid in surgical planning. On the flip side, if your rest and exercise ABIs are normal in a patient coming in with leg pain symptoms, if they're diabetic, you should do toe brachial index pressures. And then if those are greater than 0.6, then you can stop and you can say it's probably non-vascular etiology. But if your toe pressure index is less than 0.6, then you need to, that's indicative of this person having PAD. And then obviously, if you don't have evidence of PAD, then you can search for other non-vascular etiologies of the person's symptoms. So again, and then to wrap up, the different modalities that you have, duplex ultrasound, class 1 indication, MRA, class 1 indication, and then CTA is a class 2A indication. And really, the one advantage I should point out about CT, which can be a disadvantage at times, and it can be an advantage at times, is the calcification. So the disadvantage from that is that oftentimes calcifications can make it hard to identify stenosis within a vessel because of the blooming artifact on the CT, especially in small vessels. But at times it can also be an advantage because the calcification burden can have important prognostic value as well. So let me pause there and then open it up to any questions or comments from the audience.
If you're a diabetic, why would you go for the toe?
So because oftentimes they can have non-compressible vessels, so their ABI can appear to be normal or supernormal, but it actually is not the case. Yep. And the other reason is because they can also have small vessel disease, and the ABI wouldn't be able to pick that up.
Does the pulse volume records help in the diabetic stimulation?
Yeah, so the diabetic patients, the pulse volume recordings can be helpful as well. And again, I'll be, Shah was supposed to talk about the ultrasound piece of it. I'm not the expert on vascular ultrasound, so I'm pinch hitting for that part. Yep. Any other questions? Comments? Okay. All right, thank you.